Here we are at Charing Cross 2026, and today we've got members of the Vascular Access faculty with us today to talk about device-created fistulas. We've got Alex Mallios, Kate Steiner, and Bart Dolmatch. And I wonder, Bart, if I could start off with you. Device-created fistulas, percutaneous AVFs or endoAVFs, they're introduced around 10 years ago now, and we've used them, but it seems they've not really taken on in the way that we were promised. We were promised that perhaps interventional nephrologists would be doing these in their lunchtime. We were promised that these would take over and get rid of surgical fistulas. Have you got any views on why that might not have happened?
Well, I think what we've seen from the clinical studies that were early on, that creating fistulas was very successful with these two different devices. The issue is that they were fistulas that were created, but maybe not functional for use in hemodialysis access. What we appreciated over time is that it was more than a procedure, it became a program, and patients had to be followed very closely. And I think many of us weren't prepared for the ongoing maintenance of these newly created fistulae so that the patients could ultimately have successful cannulation for hemodialysis.
Sure. So can I take that to you, Alex, that you were a pioneer and you had a program that did work, and you have many patients and nearly did create or supersede surgical fistulas in your practice, I think, didn't it?
I have. Yes, thanks, Nick. Very nice to have this discussion, actually. Yeah? What a twist in the overall plot, having ellipsis disappearing and appearing back again. I agree with Bart. It was more like creating a new program, a shift of the paradigm, and I think this is what didn't go well, because the nephrologists, interventional nephrologists, did create these during lunch or before and after lunch. By the way, the guy who actually did more than me finally was an interventional nephrologist. So
do you think this is a technical issue that perhaps it didn't catch on? People were not able to do it in the same way? I know you've trained many people around the world to do this.
No, I think it's multifactorial. I think the technology is good. I think what is different is that probably the industry was anticipating a revenue more important for a better return in investment, and it was more a commercial financial issue rather than the scientific one. And also the technology and the fistulas created were different enough from the surgical fistulas to make it that we needed an entire strategy to push it forward in a larger scale, and I think we're not successful in that.
Okay, so you mentioned there in terms of value, economics. Do you think that perhaps the outcomes weren't good enough to be able to offset that economic difference between a surgical fistula and a device? These are expensive devices.
Yeah, one thing is that perhaps the outcomes were similar enough or not much better enough to justify this initial cost. And the other thing is that already vascular access, the reimbursement for vascular access, is not a big reimbursement, especially in Europe. And we're not talking about procedures that you are going to do, for one patient here and there. It's a massive amount of patients, so it's a big burden for the system.
So Kate, let me take that to you. In terms of you trained with Alex, I think, and started off a program in the UK, but what do you think stifled that program? Was it the device being taken off the market, or do you think it was actually other things like clinical issues, economic issues?
So we had a successful endoAVF program at my previous institution. I think the only thing that stifled it was the Ellipsys going off the market, to be honest. As the others have kind of described, the actual procedure itself is very simple and easy to do. And it's kind of almost the least important part of the whole patient pathway and journey. It's the patient selection. You do need some experience and knowledge of the anatomy in the region to select patients where you think, this fistula is going to work, because that's what we want at the end, is a long-term access for the patient that's functional. And having the multidisciplinary team approach at our institution, we found really, really helpful. I had a lot of support and buy-in from our nephrology colleagues and also the nursing staff as well. And the other big one was the patients. Once you had a few patients with a percutaneous fistula, they go back to the unit, the other patients would see the fistula, they'd like it, and it kind of snowballed a little bit from there as well. So the only thing that really stifled it was, it being withdrawn from the market. So It's great to hear that, the device is back. The other barrier that we had was the economic barrier to start off with. And I think that would always keep it as it was about a sort of 10 to 15, 20% of patients, of our patients who were suitable or who had an ellipsis. And for that number to grow, there would have to be something in terms of the cost of the device or the reimbursement, the tariff, or whether the device was off tariff in order to kind of grow that number.
So Bart, in the US, the economics, is we're always hearing, is a very different situation, perhaps in the NHS in the UK or perhaps in European countries. Do you think that was the main problem with these things going forwards in the US?
Well, no, my understanding is that over a short period of time, the reimbursement issues were predominantly resolved so that fistulae could be made, and it was economically viable for centers to do so. Again, I think, once you take something like creation of a fistula into the hands of interventional radiologists and interventional nephrologists, then you have to embrace everything about the patient care. And that's what many of the interventionalists were not prepared to do. I mean, we knew for many years that surgically created fistulae don't always work. But a lot of times the surgeon would make a great surgery, then the patient would have a problem with their fistula and oftentimes go to someone else to have maintenance of it or maturation of it. At the point when it went to interventional radiologists and interventional nephrologists and also surgeons, then you really had to embrace the patient care part of it through and through. And you couldn't just do it as a procedure. You had to do it as an ongoing program because many of these fistulae required procedures after creation. This was a new challenge because we had to address these issues with patients. We had to address the issues with referring physicians. Sometimes we had to refer patients back to surgeons for a different kind of surgical fistula. So it put the interventionalist in a very different position. And I think that was part of the issue with adoption in the United States.
Again, Alex, how would you answer that? Because you got this successful, you did more interventions on these patients, but your view, I think, was as long as you get a good working fistula at the time, you've got to put the effort in to get that there.
Absolutely. So I must say that I was a believer, I'm still a believer, because what I saw was that we were getting very good fistulas in the long term. So hemodynamically, these fistulas, their behavior is very much like a distal fistula because they have radial artery inflow, multiple venous outflow. So in the long term, they're better fistulas. Yeah, they're like a very good old Semino fistula. So the answer would be to have more people like Kate. Yeah, more people that will go the extra mile to do the teamwork, to go and train the nephrologists, explain the technique, explain the differences. And I think the places that we had good results were the places that where was a team effort that was able to make these results and diffuse the technology and make people part of the revolution. Yeah, that's what we need.
So we need more people like you, Kate.
Tell my husband that.
But I think the point is we need more people who can run a team like that for this sort of service, don't we? That actually what we hear from a lot of people is they're great fistulas, but I can't cannulate them. No one can cannulate these things. And I think that gives a much wider improvement program for vascular access that, we have to invest in the nurses that are cannulating fistulas to make things better, don't we?
Yeah,
But
I mean, we used to see them together. I mean, that was one of the big steps that we did was when they came back for the follow-up, the first couple, myself and the vascular access nurse, I'd scan and the nurse would see. And that was a real two-way learning curve because I would learn what they could cannulate and they would learn what the fistula flow looked like. And then after, about 10 cases or so, we didn't need to see them together because we both could understand each other and what the needs were.
If I could chime in.
Yeah, please do.
Yeah, I mean, I think if we're going to go forward with creating percutaneous fistulae, then the next generation would be something that requires less ongoing maintenance, surveillance, procedures, so that one could do a procedure and have a good chance that the patient will be able to use the fistula within a month or two with successful dialysis. I mean, I think the three problems that were encountered with the first generation devices, one was flow into the deep veins that couldn't be accessed for hemodialysis. Number two, troubles at the site of the anastomosis with fibrotic constriction and so forth. And the third is oftentimes this dual outflow with flow into the basilic and cephalic venous systems, oftentimes more flow into an inaccessible basilic vein, So if there were to go forward, I think we need to have something that will solve some of these problems so that we won't have to do embolization, ligations, more instruction at the dialysis unit for how to cannulate dual outflow fistulae, and so many of the issues that required ongoing training and care and cajoling and patient education to dialysis center education.